Welcome back to the Deep Dive. Today, we're zeroing in on a very specific group of our listeners.
We are.
If you're a plastic surgery resident, maybe you're driving in right now or you're deep in the library prepping for the FRCS or your boards.
Yeah.
This one is for you.
Yeah, this isn't a general overview. We're cutting right to the chase. A high-yield, rapid-fire revision on maxillary fractures, specifically the LeFort classification system.
It's the absolute bread and butter of facial trauma, but as you know, the examiners want the details.
Oh, they love the minutia.
The exact fracture lines, the buttresses, the OR decision-making. So think of this as your audio Viva session.
A simulation, yeah. We want to get you fluent in this so you can just walk in there with total confidence.
Exactly. Okay, before we dive in, just a little housekeeping. If you want more of these revision sessions, please hit that follow button and make sure you don't miss them.
And if this helps you, nail a question in the exam, give us a rating or a review. It genuinely helps other trainees find the show.
Also, let us know what you need. Drop a comment. Hand surgery. Burns. We build the schedule around what you guys are asking for.
Absolutely.
And one last thing. This is the free revision material if you want our Journal Club episodes or the Clinical Cases series where we go through real, complex patients.
Which is honestly the best prep for the oral boards.
You'll need to grab the premium subscription for that.
It's where we apply all this theory to the messy real world.
Okay, pitch over. Let's get to it. The midface. To understand how it breaks, you first have to understand how it's built. It's not just a block of bone, is it?
No, not at all. It's an architectural marvel, really. It's designed to transmit the huge forces of chewing right up to the skull base. And it does that with a system of pillars, or what we call the buttress system.
And this is such a key concept, because when we talk about plating later, we're really just talking about rebuilding these buttresses.
That's it exactly. You have to think of it as a frame with these thick struts, and we divide them into vertical and horizontal buttresses. The vertical ones are the main load bearers.
Okay, so let's trace those vertical pillars. I think if you can visualize them, the whole system makes more sense. There are 3 pairs, right?
3 pairs, moving from central to lateral. First, you have the nasomaxillary buttress. It runs right alongside the piriform aperture, the nose opening, and goes up to the funnel bone.
That's the central pillar.
Okay.
And moving outwards.
You get to the zygomaticomaxillary buttress, the ZM buttress.
The powerhouse.
That's the one. It runs from the alveolus up through the zygoma and connects to the lateral orbital rim. It's the key pillar on the side of the midface.
And the third one, the one people sometimes forget.
The pterygopalatine buttress. Yeah, it's tucked away posteriorly, connecting the maxilla to the pterygoid plates. So you've got a central, a lateral, and a posterior strut.
And what about the horizontal ones? They're like the cross beams holding it all together.
They are. They stop the face from splaying out. You've got the alveolar arch, the infraorbital rims, and the zygomatic arches. But mechanically, it's those vertical pillars that maintain the facial height.
So we have this scaffold. And the classification system is all about how this scaffold fails. Which brings us to René LeFort, 1901.
A very different era for medical research ethics.
I was reading about his methods. It's pretty visceral.
It is. I mean, he wanted to find the lines of weakness, so he took cadaveric skulls with the soft tissue still on and just subjected them to blunt trauma.
With wooden clubs and by throwing them against tables.
Exactly. And then he'd boil them down to see the fracture patterns. Crude, but, brilliant. His 3 patterns are still what we use today.
So let's walk through them. Before the 6, the starting point.
Also called the horizontal maxillary fracture, or for extra points, Guérin's fracture.
Guérin's fracture. Good one. So what happens here mechanically?
You've basically sheared the entire tooth-bearing part of the maxilla clean off the face. We call it the floating palate.
Okay, trace the line for us.
It runs transversely, straight across, through the base of the piriform aperture, then through the base of the maxillary sinus, and this is the critical part, it travels all the way back to fracture the pterygoid plates.
The pterygoid plates, that's the constant feature, isn't it?
It's the one non-negotiable. If the pterygoids aren't fractured, it is not a LeFort fracture, period.
So clinically, you grab the upper teeth and the whole palate moves, but the nose stays still.
Correct. The upper face is totally stable. The floating bit is the alveolus, the hard palate, and the lower part of those pterygoid plates.
All right, moving up. LeFort 2 accident, the pyramidal fracture.
And the name is perfect. The mobile segment is literally a pyramid in the middle of the face.
The anatomy gets trickier here because now we're involving the orbit.
It does. So it starts higher across the nasal bones. Then, and this is a key detail, it goes into the medial wall of the orbit, specifically behind the lacrimal bone.
And why is behind the lacrimal bone so important?
It distinguishes it from other naso-orbito-ethmoid patterns. The line runs behind the lacrimal sac, comes out across the medial infraorbital rim, and then shoots diagonally down and out under the ZM buttress, and then again
Smashes the pterygoid plates.
smashes the pterygoid plates.
So the cheekbones themselves are stable in the LeFort too.
They are. The zygomas are solid, but the nose and the maxilla are loose. If you grab the teeth and rock them,
The nose moves with the teeth.
the nose moves, but the lateral orbits, the cheeks, they're completely still.
Which brings us to the most severe one, the LeFort 3.
Craniofacial disjunction. The name says it all. The entire facial skeleton has been ripped off the skull base.
This is a massive force injury.
Huge, high velocity.
And the fracture line here just traverses everything.
It does. Starts right at the top through the nasofrontal suture. It runs deep across the orbital floor to the inferior orbital fissure.
So the whole orbital floor is gone.
Yes. From there, it follows the sphenozygomatic suture and then breaks out laterally through the zygomatico-frontal, the ZF suture. And to finally release the face, it has to break the zygomatic arch and, of course, the pterygoid plates.
So in this case, the cheekbones are part of the floating fragment.
Correct. The whole face is loose. You pull on the teeth, and the entire mid-face, cheekbones included, moves.
And these patients present very differently.
Oh, drastically. They're often unconscious. You have to assume there's a head injury, a high chance of a CSF leak, significant orbital trauma.
So this is not just about fixing bones.
No, this is about saving a life and saving their vision. You need neurosurgery and ophthalmology involved from minute one.
Now let me play devil's advocate. We learn these neat lines. In reality, on a CT scan, do you ever see a pure LeFort fracture?
Almost never. It's a great point. Trauma is messy. You get asymmetry, like a LeFort semero on one side and a thur on the other, or you get a sagittal split right down the palate. The classification is a framework, but we're to talk about it.
But the CT is the real story.
The CT is the truth.
Okay, let's switch to management. We've made the diagnosis. What's the main goal in the operating room?
It's two things, appearance and occlusion. We want them to look like they did before, and we want their teeth to bite correctly.
Which surgically means restoring facial projection and height.
Exactly, pulling the face forward and getting that vertical dimension right.
Okay, so we have a few options. When can you get away with conservative management?
Rarely. It's only for a totally undisplaced, stable fracture where the bite is absolutely perfect. A LeFort that hasn't moved. And even then, you're watching it very closely.
And close reduction, using arch bars and wires.
It has a role in emergencies. If you have massive bleeding or a CSF leak, pulling the bones forward and wiring the jaw shut can act as a tamponade. Or for a patient who just can't tolerate a general anesthetic.
So for almost everyone else, it's ORIF, open reduction internal fixation.
That's the gold standard. You open it up, put the bones back, and plate them.
Before we even make a cut, though, the airway. This is a classic Viva question.
It is. You can't have an oral tube if you're checking the bite. So you'd think nasotracheal intubation.
But wait, in LeFort 3, the skull base is fractured.
Exactly. Sticking a tube blindly through there is a terrible idea. There are reports of tubes ending up in the cranial cavity.
So what's the answer?
For a severe 2, or any 3, a nasal tube is probably contraindicated. You need to be thinking about a submental intubation or a tracheostomy.
That's a key point. Another thing, pre-injury photos.
So important. The family smartphone is your best friend. You need to know what their facial proportions look like to guide your reduction.
All right, airway is secure. Let's talk incisions. How do we get to the bones?
You start from the bottom. For every LeFort fracture, you're going to need an upper buccal sulcus incision inside the mouth. That gets you to the ZM buttress.
Okay, what about for a LeFort dilatant or third, where you need to see the orbital rim?
You'll add a lower eyelid approach, a transconjunctival or a subciliary. That gets you onto the infraorbital rim and the floor.
And for the very top, the nasofrontal region.
You could use a small glabular incision, but really for a complex 2 or any third, you're probably going to need the big gun.
The coronal?
The coronal incision, scalp flat from ear to ear. It gives you access to everything. The nasofrontal suture, the ZF, the arches, unparalleled exposure.
So we're in. First step is mobilization, and that's not always gentle.
No, if the face is impacted backwards, you need serious force. We use Rowe's disimpaction forceps, which basically grip the palate, and you have to physically rock the maxilla forward to break the impaction.
Once it's loose, how do you know where it goes?
The teeth are your guide, the occlusion. You put the patient into IMF intermaxillary fixation, wiring the jaws together. You create one solid block and rotate that up until the bones make contact.
Then you plate it. What's the philosophy there?
You match the plate to the load. On the big vertical buttresses, the ZM and NACE maxillary, you use stronger 2.0 millimeter plates. For smaller fragments or non-load-bearing areas, you can use smaller plates.
Is there an order of operations for a LeFort the Fort?
LeFort the first, you start with the ZM buttresses. Plate those first to set the width and height. Then plate the nasomaxillary buttresses if you need to.
And a LeFort too.
Same start. ZM buttress first. Then you move up and plate the infraorbital rims. Then the nasofrontal area if it's involved.
And for the big LeFort third.
You generally want to build from the outside in. Start laterally. Plate the ZF suture first. Then you'll likely need to plate the nasofrontal suture and the zygomatic arches to reestablish the facial frame.
Once the plates are on, are you done?
Not yet. The moment of truth. You have to take them out of IMF and check the bite one last time. If the occlusion is perfect, you've won.
And if there are big gaps, comminution.
Then you might need to consider some bone grafting to make sure everything heals solidly.
Fantastic. A great run-through from the buttresses all the way to the final plate.
From the floating palate to full craniofacial disjunction.
Before we sign off, I want to leave everyone with one final thought. We kept mentioning the pterygoid plates.
We did. And here's the thing to think about on your drive home. Why are the pterygoids the common denominator in all three fracture types?
It suggests they're like a built-in crumple zone for the skull base.
That's exactly it. It tells you how force is transmitted. The facial skeleton might be sacrificing itself, breaking away at that weak point to protect the brainstem and the cranial contents from that shockwave.
The face as a protective shield. A great way to visualize it.
Just picture that the next time you look at a skull.
All right, that's it for this revision deep dive.
Hope it sticks.
Remember, if you want to see how this all applies to a messy, real-life patient, go subscribe to Premium for the Clinical Cases series. We've got a complex panfacial fracture coming up.
Yeah, that one defies all the textbook rules. You won't want to miss it.
And please, rate the show if you learned something today. It really helps us out.
Good luck with the exams.
See you next time.